Imagine our country, South Africa, as a human body. Now, what picture comes to mind when you think of that? You think of a healthy, strong body ready to tackle absolutely anything? Or do you think of a weak, diseased body, hardly able to stand? Now, as a doctor in the public service, I have the unfortunate picture of South Africa as quite an ill person. He's coughing with TB. He's ravaged with HIV. In fact, he's got a bit of a paunch. He's getting diabetes in his old age. In fact, he's got a blue eye. He's getting beaten up. There's so much trauma that we see. And he probably has a psychiatric illness as well. This is the unfortunate reality, the picture that we see of health in the country. Now, if we had to liken certain parts of the country to certain parts of this body, we could say perhaps that, and maybe I'm a bit biased here, that Cape Town is the heart. And maybe treading a bit dangerously here, perhaps, Gauteng, being the business center is the brain. Maybe Kimberley with the big hole could be you could use your imagination. But all jokes aside, if I had to ask you a serious question, if I had to ask you what role do you think healthcare workers, doctors, nurses, dentists, physiotherapists, paramedics, what role do you think they play in the body? And it would have to be the white blood cells. Because the white cells fight infection and disease. And they do so on a daily basis without the rest of the body knowing about it. And one thing is absolutely clear. The health of the whole body or the whole system depends on their ability to do their jobs well, accurately and efficiently and without mistakes. So why is our body so ill? It's clearly not the case that, poor decision making by our white cells is the only cause. There's so many reasons, right? But it really helps to have a good immunity. It really helps. So, where do we stand? Where do we stand? If we take the decision making of our white cells, of our doctors, of our health force, and we say, well, it's over here, but it could be over here. How big is that gap? How bad is our immunity? And it's a very difficult thing to measure, right? You can't measure the decision making of healthcare workers throughout our entire country, but there are a few studies that give us some indication. And some of us have really good anecdotal sort of experience on the ground. One study, for example, looked at the way doctors and nurses adhere to standard treatment guidelines, because that's a way to benchmark it, right? You look at what is objectively the best standard and what's actually being done on the ground. One study at a South African hospital looked at the way our doctors and nurses follow national guidelines for something as simple as high blood pressure management. And they found a 22.5% dismal adherence to the standard guidelines. That means that about 80% of patients were not getting the care that they could get according to what is recommended. And there are many such examples. I won't go into so many of them. So this question about where medicine is and where it could be and where it should be, that's a problem. And how do we begin to address and change this? And to do so, I'm going to tell you a little story about what actually happens on the ground. So, imagine a hospital in rural South Africa, deep rural South Africa. It's remote. And imagine a nurse, and her name is Zuzu, right? And Zuzu comes to work every day. She's the senior nurse. Some days there's a doctor in the hospital. Some days there isn't. And she sees many very different patients, right? Patients with HIV, with TB, with high blood pressure, with diabetes, and she's got to make many decisions. And on this particular day, she sees Johnny, right? Johnny has HIV. And he's doing really well. It's actually CD4 count is up, his viral load is down. But he came to the clinic about 2-3 days earlier because he wasn't feeling well. He had a bit of nausea. And some blood tests were done. And Zuzu's seeing him in the consulting room, right? So what she does is she walks out to the reception area to find the only phone in the hospital. And she phones the lab. And she writes down the blood results, the liver functions, the iron, the electrolytes. And then she walks back, through the corridor, packed with patients, and she comes into the consulting room and she looks at Johnny and she looks at the results, right? Now, Johnny's on HIV medication. And Zuzu knows that there's something wrong with the results. Sometimes HIV medication can cause toxicity, right? And it reflects on the blood results. But deciding whether to stop the medication and refer the patient, and deciding whether these results are really that bad enough to warrant that, or whether you should continue monitoring and manage the patient, that's a decision, right? And that decision can be quite complex. And if you get it wrong, it's actually disastrous either way. You stop the medication and the patient goes on to develop resistance to HIV, which happens quickly, or you don't stop it and they end up dying of toxicity. So what does she do? This is a classic situation, right? It's a situation that occurs across every disease area. A South African health provider finds themselves in a situation where they need to make a decision about something. What's the best way to make a decision? Well, in medicine, there's a framework for doing that, right? You look for the best international evidence. You look for the best expert recommendations locally. You consult an expert if you can. You consult the guideline, and you look at the information about the patient, and you make a really good decision. So Zuzu wants to know what the latest recommendation is, right? But the national policy and guideline for HIV management was stolen from the clinic. It was a thick, dog-eared guideline, was stolen from the clinic three months ago. She wants to phone a specialist. But she knows that the hospital that she's phoning, she has to go through switchboard. It's going to take her 15, 20 minutes. And there are about 20 patients waiting outside. The doctor that's usually in the hospital is not there on that day. So what does she do? What does she do? She does what every single healthcare provider in the country does. She makes a reasonable decision in unreasonable circumstances to the best of her experience and capabilities. So she feels that Johnny's not ill enough and lets him continue his medication. Unfortunately, 3 weeks later, she hears that Johnny was admitted to ICU with severe liver toxicity, and he passed away. And she consoles herself by the fact that he did have a lot else going on. He was sick, he had some other opportunistic infection. But it's not Zuzu's fault. It's not her fault. It's the fault of the system for not facilitating the right conditions to give her the access to the expertise and knowledge that she needs at her fingertips to make a complex decision about a very real life and death situation. So how do we address this? Now, this is not a phone. This is not a phone. This is more computing power in the palm of your hand than the entire NASA computer system had when it launched its mission to the moon so many years ago. Well, think about that for a second. This does three basic things. It connects you to information, it processes information, and it connects you to people. Three basic things. Now let's take that and look at a situation like this is a typical decision-making situation. So, as Siraj mentioned earlier, this is the project, one of the projects we're working on in partnership with Metropolitan and the Department of Health, the National HIV Guidelines application. Let's look at the first problem in that decision-making cascade. Firstly, she needs access to information, to the latest, most expert recommendations for our setting, not any other setting, our setting. So these are the national guidelines, right? She can simply type in toxicity and come up with a guideline on how to manage toxicity and drug toxicity in our setting. But it can be a bit complex, so let's help her process it. Let's let her enter a patient age through entering a birth date, entering a sex, and entering the blood results, so that we can get the age and sex-specific reference parameters to make this particular decision that are designed for our setting. And then what we do is we provide her with a calculation, a bit of guideline on how to safely engage and move further, how to safely view the situation and make an appropriate decision. And let's give her an alert that for this particular patient, for Johnny, his liver functions were well beyond the recommended limit, and that she should consult an expert and possibly stop the drugs. But we don't have to stop there. We have some of the, if not the leading HIV experts in the world in our country. Could we not connect frontline healthcare providers in those kind of settings and tap into that expertise using mobile technology? What if we gave her the ability to simply access one of those experts who would commit for a day to be online and answer queries from the front line? A simple question and answer through an instant messaging systems, technology we use every single day, but we make it our own. And what if after that, we could save her the logistical and the practical hassle of sending that patient and referring that patient, and let her refer directly from the same application? And what if after that, we could give her and the patient and perhaps the ambulance the exact location and contact for that particular hospital? And what if after that, we could see every healthcare worker as a node of information and get her to directly from her phone report that this was an adverse event, so that the next time when it happens, or the next time we put out drugs, we can put out warnings about these things. Ladies and gentlemen, what I've demonstrated is this technology designed for our people. A fully indigenized solution integrated into the workflow of our health system. A technology and a solution that reduces the complexity and impracticality of performing clinical care in an otherwise overburdened and frustrated system. A technology and a way of thinking that could put power back into the hands of our healthcare providers. And I think, as was mentioned earlier in another talk, and I hope I get this right, it's a shift of power away from the center and into ourselves. And what we've demonstrated is one decision pathway in one disease area. There are so many more decision pathways like this in HIV, for example, whether it's the management of mother-to-child transmission, whether it's the starting a child on antiretrovirals. There are decision pathways when we make decisions on managing our diabetic patients, when to start medication, when to start insulin, and so forth. Decisions about who to refer in terms of patients with dermatological or eye conditions. Decisions, maybe in a more sinister manner, about which patients to refer for cancer screening and which patients we don't. How to make the best decisions. Each one of these decisions fundamentally shapes the health of the country. And each one of them will be made better with the right access to expertise, with the right computational software, and with the right access to information. We have a lot to learn from our internal compositions. Every cell in our body is connected. And it's in our cells' connectedness that they perform wonderful and complex tasks which ultimately make us the brilliant and successful human beings in societies that we are. If we could tap into that kind of connectedness and connect our workforce, our health force, through technology, in an intricate web, whereby we provide the right decision support, guidance and information to each other at those absolutely critical points within the system. We'll come to a point in the future where when I ask the question, how do you picture South Africa? It won't be as a sick, diseased individual. It'll be as an individual with the strongest immune system and the ability to be robust and tackle absolutely any challenge in the world. Thank you very much.